The world has changed a lot since 1978, when the Alma Ata Declaration launched primary health care as a holistic approach to the world's health problems. The target was universal health for all by the year 2000. Some say Alma Ata never fully delivered on its promise. Others say these days primary health care is more relevant than ever.
We believe that primary health care is not only the way forward for Africa, but it's the way forward even for the whole world.
This report shows some ways in which primary health care is being used to meet the challenges of the 21st century. Ethiopia is on the move. 2007 marked the new millennium in the Ethiopian calendar, and hopes and expectations are high. The economy's growing fast, and young people are coming to the cities in the hope of finding work. But Ethiopia is a poor country with major health problems, including mother and child mortality rates amongst the highest in the world. A huge effort is underway to meet the Millennium Development Goals, and that means fast-tracking improvements to the nation's health.
The philosophy of the health extension program is if we can provide the right skill and knowledge to the communities, then they can produce their own health. It's just as simple as that.
Vaccination, there is syringe is needed.
In just a few years, the program is training 30,000 women as health extension workers. They'll deliver immunization, family planning, nutrition advice and other targeted services to all of rural Ethiopia by 2009.
We need to really scale up very aggressively. There is a huge government commitment, and there is a huge support and acceptance by our partners, also the donor community.
80% of Ethiopia's people live in rural villages, often isolated from medical services. The aim is for a health post in every Kabali, a sub-district of around 5,000 people. It's a development on previous primary health care experiences.
Before we started the health extension program, there was a very candid evaluation that was done on the past performance. The two important lessons were lack of ownership by the community itself, and there were no formal institutions that were leading these primary health care goals. So we addressed these two major problems.
Each health post is staffed by 2 full-time workers. They spend 75% of their time doing prevention and health promotion.
ወደ ቤት ለቤት ሲሄድ በመጀመሪያ ደረጃ የህብረተሰቡን ችግር ምን እንደሆነ ለማወቅና ለዛ ለተፈጠረው ችግር እዛው ቤት ውስጥ ሆኜ መፍትሄ ለመፈለግ ስለሚያመቸኝ
Model families are trained to help spread good practice, and mother and child health is the priority.
In our primary health care, health extension program is the front line, the first line. And we have health center expansion services as a second line, which focuses more on basic and comprehensive obstetric care.
ህብረተሰቡ የራሱን ጤና እንዲጠብቅ ያ ሁሉም ነገር በራሳቸው እጅ ያለና ከግንዛቤ እጥረት የማይጠቀሙ መሆኑን እኔ ስመጣ ከዚህ በፊት ብዙ ችግሮች ነበሩ። የሰዎች የራሳቸው መጸዳጃ ቤት የላቸውም፣ የሚጠጡት ውሃ በንጽህና አይዙም፣ አካባቢያቸውን አያጸዱም፣ ቤታቸው የተናፈሰ እንዲሆን አያደርጉም እና ያ ሁሉ ችግር አሁን በአሁኑ ሰዓት ተቀርፎ ነው ያለው።
The health post delivers selected treatment. Here this woman is being tested for malaria, one of the program targets. But the focus is on prevention rather than cure and facilitating community action. Targeted issues like HIV/AIDS are discussed in community conversations and plans decided. The result is a drop in all major infections.
We are seeing really encouraging results in areas where we have already deployed These 30,000 health extension workers will reduce the major mortalities significantly, because each and every individual you're assuming is taking the responsibility, and that will be a shortcut to make a huge impact that we're looking for.
The 1994 genocide decimated Rwanda's fragile economy base, destroyed a large share of country's human capital, and eroded the country's ability to attract private sector investment. Child and maternal mortality increased during and after the genocide, but now is decreasing significantly. The main source of success for the boost of the primary healthcare services in Rwanda was the implementation and a rapid scaling up of innovative policies such as performance-based contracting and the micro-health insurance scheme. Immaculée Mujawamaria lives in Gahanga sector in the rural neighborhood of Kigali. She is 44 years old and head of a family of 5 children since her husband was arrested because of his participation in the 1994 genocide. As 80% of Rwanda's population, Mujawamaria's occupation is agriculture, and she earned no more than $1 per day. Isabiriza Francine, a 20-year-old girl, is the second daughter of Mujawamaria. She got pregnant while living with her mother. Her partner refused neither to marry her nor to bear the cost of the pregnancy. Mujawamaria, as many Rwanda's women, was the one to take care of her daughter's pregnancy.
Mugejeje gangu kwa muganga baramusuzuma baramubabyaza nta kibazo. Amaze kumubyaza ubwo nkagira ubwoba ntise amafaranga bazanse nzakuraye ko ndi umukene. Ubwo ngubwo maze kubyara tugeze igihe cyo gusezera kujya gutaha habanyitse amafaranga 200 yonyine nduva ndishimye nari ko wenda banca nk'ibihumbi 20 cyangwa 15 ariko byabaye 200.
Umwana hashize icyumweru bona tarambura amaguru. Ngezeyo rero baramusuzuma bahita bamarandevu bahita bamatarasifere yo kujya Kanombe. Ngeze Kanombe naho bahita bamatarasifere yo kujya CH.
Gahanga Health Center is one of the health facilities which successfully implement the scaling up of community insurance scheme. This boosted the use of primary health care services among the population living in the catchment area of the health center, approximately 20,000 people. The insurance covers the cost of services at the health center, and in case of transfer at the district hospital and the referral hospital.
Ariko noneho bamaze kumubaga bamukuyemo iki kintu cyari kimurimo umwana yabaye umwana ahubwo ngiye kumubaga kwe nabonaga rwose pe ko nimuka intanga ntazongera no kuhagaruka kubera amafaranga nzatangaye ariko noneho mituwe ningira kamaro rwose ngiye ko mbibona.